As we all know, with any presenting pathology, a, an important aspect of examination includes a comprehensive history taking. This comprehensive history, especially of the presenting complaint, should be related to the pain, the type of pain, the intensity of pain, the location, and the duration of pain are all very important factors. Together with activity levels, also a medical history as to whether the patient has diabetes, rheumatoid arthritis, or other significant medical conditions. Also, what type of footwear is worn during most of the day, during the principal activity of the patient. So, in order to assess this patient's pain, it's very important to apply firm pressure and to palpate the areas, because the location of the pain is very important. So if the pain is present on the metatarsalophalangeal joint itself, it will tell us one thing, that the condition could, for example, be capsulitis or some kind of arthritis, while if the condition is between the joints, such as in this case, it could tell us that the lesion, that the presenting complaint could be possibly interdigital bursitis or maybe Morton's neuroma. And in order to assess whether there is a Morton's neuroma, we apply lateral pressure and at the same time pressure from the plantar aspect of the forefoot, in order to determine whether there is that clicking feeling which we call Mulder's click. In this case, there is a distinctive click upon application of lateral pressure and pressure from the plantar aspect of the foot, which could be indicative of the presence of a neuroma. So for the purpose of this presentation, what I'm going to do is I'm going to mark the area with a skin marker, because later on we will need to know where we have to offload using foot orthosis, where we have to offload the area. The next stage of the examination involves the examination of the range of motion of the major joints of the foot. And starting with the ankle joint, what we really do is we put the foot at subtalar joint neutral position, and we allow a dorsiflexing force with all our not really with all our strength, but quite powerfully. And you see in this case that this patient has limited ankle dorsiflexion, meaning that the foot did not dorsiflex sufficiently, even though I am applying quite a considerable amount of force. So my first diagnosis in this patient would be limited ankle dorsiflexion, or in podiatric terms, what we call ankle equinus. The next joint that we're going to look at is the subtalar joint. As we know, the subtalar joint gives us inversion and diversion and inversion and diversion, and there is twice as much inversion as there is eversion. Moving further distally, the mid-tarsal joint gives us motion around the oblique axis and around the longitudinal axis, and we are looking for the ranges of motion. We're looking for the possibility of hypermobility or rigidity around these joints, and in this case there is quite an adequate amount of movement. Moving further distally, the first ray is examined by grasping the first metatarsalophalangeal joint and the other metatarsalophalangeal joints, and moving the first ray upwards and downwards in order to determine the position of the first ray, whether it is plantar flexed, dorsiflexed, or whether it is rigid, or whether it is hypermobile, because it's a very important data that we need when we are designing any possible orthosis. After that, we go and check the fifth metatarsalophalangeal joint, which shows in this case a normal and adequate range of motion. And to finish, we look at the first metatarsophalangeal joint, which should normally dorsiflex by about 65 degrees. Limitation of this dorsiflexion is known as hallux limitus or hallux rigidus. And the test which we can do is called the Jex test, which is done by applying a force underneath the first metatarsophalangeal joint and then trying to dorsiflex the hallux. In this case, the test proved to be positive, so there could be the possibility that this person may actually have functional hallux limitus. So an important part of the weight-bearing examination is to look at foot posture. And in order to remove subjectivity from this examination, one can use what is known as the foot posture index. So the foot posture index is an important tool that is validated and is very reliable for quantifying the foot posture. The foot posture index has 6 criteria, and in these 6 criteria, one must score a positive score if the foot is pronated, and a negative score if that particular criteria refers to a supinated foot. So in a pronated foot, the talonavicular joint bulges medially, while if the foot is supinated, this would it would not bulge, but rather there would be a depression in this area here. Another criteria is are the curves above and below the calcaneus. Okay. Together with that, then the third criteria is palpation of the head of the talus. In this case, I can clearly palpate the talus more on the medial aspect, so it is scored positively for a pronated foot type. The other criteria include the inversion of the calcaneus. If the calcaneus is everted in a pronated foot, it is scored positively. And to conclude, the last criteria is what we call the too many toes sign, when the foot is abducted, because abduction is, as we know, is a part of pronation. When the foot is abducted, it means that this is a component of pronation, so it is scored positively. Another criterion of the foot posture index is the congruence of the medial longitudinal arch. As we know, the more the foot is pronated, the more the longitudinal arch becomes depressed and lower. So the maximum score of +2 would be given when the foot is totally flat. However, when the foot is in a cavus, foot, the arch would increase, and so we would score this as a -2. Very importantly, when we are examining a patient in a weight-bearing situation like this, is to check for movement of the first metatarsophalangeal joint. This is a test called the Hapscher maneuver, in which we try to elevate. It is very important to try to elevate from the interphalangeal joint and not from the distal part of the hallux. We try to elevate this, and as we can see, even though I am applying a lot of pressure, the toe does not dorsiflex. This indicates that the person has functional hallux limitus. So if we were to put the foot in a neutral calcaneal stance position, as opposed to the position that it was before, which was the resting calcaneal stance position, and we hold the foot in a neutral position, we can see that when we dorsiflex the foot, there is really normal dorsiflexion, and the way the windlass mechanism is seen to function. So what happens is, when I raise the big toe, is that there is an increase in arch height, there is supination of the foot, plus external rotation of the lower leg. This is known as the windlass mechanism. So when I do this, the windlass mechanism should be seen to work. In this case, it is not functioning, so it really confirms our our diagnosis of functional hallux limitus.